Welcome, and thank you all for coming to this year's University of California Global Health Day. My name is Patricia Conrad, my pronouns are she, her, and I am the co-director of the UC Global Health Institute, which includes all 10 campuses of the University of California. It is my honor to introduce the 21st President of the University of California, President Michael Drake, as our welcome speaker this year. This is a very special honor for us because President Drake actually was the first to host the UC Global Health Day when he was a chancellor at UC Irvine. Please join me in welcoming President Michael V. Drake.
Thank you very much, Professor Conrad. Great to see you and great to see everyone on the screen. It's amazing that it's been a dozen years since we had the first Global Health Day at UC Irvine, and actually the years before that when Tom and Hailey and so many others were working on putting this together. It was great to see everything come together and great to see the energy that has lasted throughout this decade. And my comments really will be brief. The program today is going to be quite interesting and quite relevant. What a year it's been for the world and what a year it's been for global health. We've had so many indicators of how connected we all are, how it really is one planet and one world, and how the health impacts or health circumstances of one part of the world can affect another part of the world, and how it keeps cycling and that we're all together. So the work that you're all doing to recognize that and to address that fact is critically important to our future. And also it's been a tragic realization over and over again, the inequities that we see in our world and the real effect that racism and bigotry have on our world and have had on our world and on our civilization for these centuries. And a time of reckoning is, of course, long overdue, and the opportunity for us to really address those systemic and functional things which set our world up to be non-equitable, to place many of our fellow citizens at extreme risk, challenged every day. Those are things we really do have to face as a global community, and so pleased to see that focus. When we spoke at the very beginning of the concept of having a system-wide effort in global health, there was a lot of discussion about the power of 10, the 10 campuses coming together and doing things in a way that no one campus could. What we've really seen, I think, during this last decade is it's the power of 10, but then the power of 100, the power of 1,000. All of the people who worked on this great effort, and the fact that those people have to, the opportunity that those people have to really affect the lives of millions and millions of our fellow citizens. So I congratulate you on your work and thank you for that work. My role is really over. I'm here as the warm-up to be able to get things started and to get the day moving. I look forward to following along with the activities of the day, and then really in supporting all of you and all that we can do as a university and as a world community to help support the efforts that we all need to put forth into making this a safer and healthier and better planet. Also, I will say maybe it's my final comment that it's one of the things that the Zoom lives that we've been living over these years have shown us is that we can be in separate places, but at the same time be connected. And so it's very good today to be able to have our Global Health Day really be a truly global effort. And I welcome people from all across this country and around the world. So with that, let me wish you a very happy and productive day. I look forward to the program. Thank you, and fiat lux.
Thank you so much for the warm welcome to UC Global Health Day, President Drake. My name is Sun Yu Cotter, and my pronouns are she, her. I'm the Deputy Director for the UC Global Health Institute, which we will call UCGHI, and we'll use this acronym throughout the event. I'm also the co-chair for the UC Global Health Institute's Black Lives Matter Task Force, and I'll be your MC for today. Before we continue, we'd like to do a land acknowledgement to recognize and respect Indigenous peoples who are the traditional stewards of this land and enduring the relationship that exists between Indigenous peoples and their traditional territories. We would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UC San Francisco sits upon and where the UC Global Health Institute's core administration is located, their home. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. I also want to invite you to think about where you're tuning in from right now. This is an opportunity for each of us to acknowledge and honor the Indigenous people whose ancestral land we are on. Now, it is my honor to welcome our opening plenary speaker, Radmilla Cody. She is a community advocate, a community organizer, Grammy-nominated singer, and a mother. Please join me in welcoming Radmilla.
Yat Shikado Shitana Trahasinto, She Radmilla Cody and Chiek, Ashit and Schlin, Ahitla Bashichin, Akidene Dashiche, Nahitla A Dashanella Kut A Sun Schle. Ado Hehan Hidi Dashni, the US Global Health Day 2021, Huliaki Hagodashaton.nidiki.com and Nache Nihijahasi. My name is Radmilla Cody, and my pronouns are she, her, and hers, and it is an honor to be here with each and every one of you for the US Global Health Day 2021 and share a virtual space with all of you, my relatives. I am of the Rideau Kerchee clan, born for the African American. My maternal clans are of the Mexican clan, and my paternal clans are of the African American. And this is how I identify myself from the Diné Nation, the Navajo territory. I would first like to say Hehe Nsago, thank you to the UCSF for sending much needed help to the Navajo Nation when we were being overwhelmed by COVID-19 cases. Your kinship and hearts will not be forgotten. I also extend kinship to our Asian and Pacific Islander relatives. May we all unite to protect each other from the terrorism of xenophobia and xenophobia. When the current pandemic was becoming more severe on the Navajo Nation, the media did what it usually does and play up the poor Indians' story. To better understand our situation as Diné people, I would like to introduce our own model of wellness called Sa'anave Bik-Ehojon, which is our journey to live a long life of health and happiness. To help us on this journey, we have 4 guides and philosophies of place and being. To the east direction is Nsahakes, our thought process and critical thinking. We analyze the disruptions of our lives. What is causing myself, my family, my community, and the land harm? To the south direction is Nahata, planning. We place ideas around us to build one or multiple strategies to restore balance. To the west direction is Ina, life or essence. We implement long-term strategies to live healthy and dignified lives. And to the north, Sihasin, hope, reflecting, and protection. Which strategies failed? How do we prolong and improve the ones that succeeded? The traditions of Indigenous people does not mean we are museum pieces, fragile, unchanging, reminders of the past that are to be only studied or romanticized by settler society. Our traditions are lifeways. They are living and absorbed new knowledge. The foundation of our lifeways is our kinship with the lands that taught these ways of being and growth. Where knowledge is learned matters. There are thousands of settler scholars from religious and educational institutions who are heavily cited as opposed to us, the current knowledge keepers, who live outside the realms of dusty journals or a thesis hidden behind a paywall. Therefore, we demand land back instead of land acknowledgements. Using our own model of achieving wellness, the diagnosis is clear. Capitalism is the greatest disruption of life today. US policies which serve imperialism prolong various diseases of our mind, spirits, and bodies. Indigenous people globally didn't choose to have our water sources and lands poisoned by mining corporations. We didn't choose to be displaced and dispossessed. We didn't choose the death ways of colonization for capitalism. Through this analysis, we founded the Info Shop, which is a collective of Diné feminists within the Navajo Nation with anarchist and communist tendencies. The Info Shop collective was formed to not only address the stigma and misconceptions of unsheltered Indigenous and non-Indigenous relatives, but to offer a space to freely study and discuss our situations as Diné, which includes confronting so-called traditionalist views of gender and sexuality. Mutual aid, much like decolonization, has been co-opted and defamed from its own radical traditions. For Diné, we view mutual aid as one of many tangible extensions of kinship. Through we ensure all, not just Diné people, can live healthy lives through material resources or through ceremonies and songs. Does not discriminate. Includes our Black relatives who are not settlers, but are displaced Indigenous people themselves. Our Black relatives have a long and intertwined history with Indigenous people on this hemisphere. Our solidarity predates the US. Medicine and other sciences have long been tools of colonization to dehumanize Black, Brown, and Indigenous people globally to further imperialist expansion. Medicine has a documented history in perpetuating dangerous inventions of race and binary genders. Science has never been apolitical when serving the goals of imperialism. Billionaires with private space companies are celebrated for manifesting the ultimate settler escape fantasy of leaving the earth rather than saving it. If solutions for health rely on someone making a profit at the expense of marginalized and poor communities, is it really a solution? We must continue to advance our analysis of intersections of power that support these disruptions of health and dignity. While on this path of decolonization, remember to not confuse decolonization with more diversity. Decolonization is not more representation. Black, Brown, and Indigenous people have paid and will always pay more than any billionaire ever has for a seat at the table of liberalism. Our future relies on us dismantling hierarchies of power rather than reproducing the harms they create. It is easy for us to point at our common enemies. It's harder to slay them together. We can start by ensuring equal access to skills and knowledge. Skill sharing is kinship. Western paternalism costs lives when ignoring Indigenous voices and experience. Equal access to health and medicine resources ensure greater chances of long-term success for any health project. Just as Indigenous people are forced into a violent domestic dependency upon the US, we must also not replicate such imbalanced relationships of power. Preserve kinship. Uphold horizontal leadership through equal access to resources and knowledge. Despite generations upon generations of trauma, our roots will always find each other. Our kinship, our solidarity will be tested over and over. The future is uncertain, but it's there for us to take. Many of us are afraid because it seems our futures have been held hostage by the rich and imperialist classes for so long. This uncertainty is a consequence of incessant abuse and humiliation by the monsters known as capitalism, colonialism, racism, and patriarchy. All four are enemies of the Diné. Slay these monsters with us. Through kinship, we are strong. I would like to share a song with you all. It's two songs, actually. It's a song, the first one is a protection song because we are still in this place of protection, in a state of protection. And in our culture, we believe that we are making our way into that state of beauty. Again, a good state of being in a good state as with the earth and with each other as relatives. And so this first song is the Protection Warrior song, and then following that song is a song about kinship, walking through life and through kinship. Yitzka Hawaii, Yitzka Hawaii, Yitzka Hawaii, Neo ha e ha e ha e ha e ha e ha e Neo na ye Yizrane got Neligo, Yitzka Hawaii. Beshit yithie hatet ego, yitzka huwowie, yitzka huwowie, yitzka huwowie, yitzka huwowie, neo ha e ha e ha e ha e ha e ha neo. Topa just chini got neligo, yitzka huwowie. Bestok is ye hatet ego, yitzka huwowie, yitzka huwowie, yitzka huwowie, yitzka huwowie, neo ha e ha e ha e ha e ha e ha neo. Besist ogi kata yolego, yitzka huwowie, Yego bits a winnie yego, yitzka huwowie, yitzka huwowie, yitzka huwowie, yitzka huwowie, neo. Ha e ha e ha e ha e ha e ha neo. Do atket nehi got neligo, yitzka huwowie. A tindi in ye kaye go, yitzka huwowie, yitzka huwowie, yitzka huwowie, yitzka huwowie, neo. Ha e ha e ha e ha neo. Na pahiten ne got neligo, yitzka huwowie. Yitzka huwowie, yitzka huwowie, yitzka huwowie, neo ha e ha e ha e ha e ha neo. Wings in she hello na sha away hey wings in she it's a logo na sha away hey she hello na sha away hey she it's a logo na sha away hey Atilishi holoko na sha away hey atilishi tsalako na sha away hey na sha away, hey, oh, lini she, it's a lago na sha away, hey, 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 yes, the clean she, Hologona Sha away, hey, yes, the clean she, it's a Lagona Sha away, hey, yeah. Thank you.
Thank you so much for that incredible performance and opening plenary, Radmilla. Before I hand it over to Sam Yang, our co-director for the Planetary Health Center of Expertise from UC Riverside, our first panel, I wanted to make a quick announcement about your questions and answers throughout the event. We definitely want to hear from all of you. So if you have any questions during the event, please utilize the question and answer function in Zoom. We do have a tight schedule though, so we might not be able to take all audience questions in real time, but we'll definitely answer many of your questions after the event. Okay, Sam, I'm going to hand it over to you for the Regional Indigenous Perspectives panel.
Hi, everyone. Thanks so much, Sun. As Sun mentioned, my name is Sam, and I'm an assistant professor at UC Riverside and also the co-director of the Planetary Health Center of Expertise. And I have the great honor of moderating, but most importantly, really learning from today's panel on regional Indigenous perspectives of health. And I think it was the most fabulous transition to this panel, having Radmilla Cody's introduction, just bringing these ideas to the forefront and really talking about how to provide inclusivity and equity through our healthcare system. So to start, I would like to have our panelists introduce themselves, and we'll kick that off with Dr. Andrea Garcia.
Hi, good morning, everyone. It's a pleasure to be here with you this morning. My name is Andrea Garcia. On my maternal side, I am Mandan, Hidatsa, and Arikara. And on my paternal side, I'm Mexican. I am currently a physician at the LA County Department of Mental Health and a proud alumni of the UC Berkeley UCSF Joint Medical Program and a former fellow at UCLA in the National Clinician Scholars Program. Thanks for having me.
Thanks so much, Andrea. And next we have Dr. Beth Rose Middleton Manning.
Hello, thank you. Wonderful to be here with you all this morning. My name is Beth Rose Middleton Manning. I'm Afro-Caribbean, African-American, Eastern European. I am speaking to you from Patwin Homelands in Davis, and I'm a professor in the Native American Studies Department and the current chair at UC Davis, and also UC Davis and UC Berkeley alum.
Wonderful, thank you, Beth Rose. And next we have Dr. Mark LeBeau.
Hi, Jimmy Sunui. My name is Mark LeBeau. I'm a citizen of the Pit Nation on my mother's side, and on my father's side, I'm Cheyenne River. Happy to be here this morning.
Thank you, Mark. And next we have Dr. Virginia Hedrick, or Miss Virginia Hedrick, whichever you prefer. I'll let her introduce herself now.
Squinakoi, not a doctor. Squinakoi Nakna Virginia Hedrick, Shregon Mewamechuk, Nekpulikla. Good morning. My name is Virginia Hedrick. I'm a member of the Yurok tribe. I come from the village of Shregon on the Klamath River. I'm the executive director for the California Consortium for Urban Indian Health and a UCLA alum. Good to be here this morning.
Thanks so much to all of the panelists. And so I'd like to start us off with our first discussion question, which we will refer to this quote to start. And the quote is pulled from a book titled Global Indigenous Health. And the quote states, Indigenous peoples globally have a keen understanding of their health and wellness through traditional knowledge systems. In the past, traditional understandings of health often intersected with individual, community, and environmental relationships of well-being, creating an equilibrium of living well. However, colonization and the imposition of colonial policies regarding health, justice, and the environment have dramatically impacted Indigenous people's health. And so for this first question, it'd be wonderful to hear from all of our panelists and to directly ask, how do you understand or define decolonization in action through the work you are currently engaged in? And so for this, perhaps we could start with Dr. Andrea Garcia.
Sure, you can call me Andrea.
Okay.
So for me, I like to think of what I do, really stretching it though, as combating structural racism through indigenizing spaces. So using my work in Native homelessness, for example, our priority is and always has been to center Native voices, to center lived experience, and to center those Native frontline workers to help us understand what works for them, as opposed to asking how they can bend and fit into the inflexible system that centers white supremacy. I think indigenizing space in this work also means telling stories that are not told, overcoming erasure and invisibility in data, and demanding multiple seats at all of the tables. Most of all, indigenizing spaces in homelessness and really beyond relies on the fact that our communities already have the answers. We know that our connection to our land, to our relations, and to our teachings positively impact health and well-being. We know this. And when talking to our relatives who experience homelessness in LA, for example, they used words such as love when talking about the services received at our Native organizations. What that says to me, especially in regards to homelessness, is that our Native people and our Native organizations and communities are already doing the good work. We simply need access to the resources, the capital to build the best dang culturally affirmative housing you've ever seen, and we need our land back in every sense of the word to continue our healing. That would be ideal and what true decolonization in action would look like to me.
That is wonderful, Andrea. And the statement of our communities already have the answers, and highlighting love is such a powerful statement. Next, we have Beth Rose.
Thank you. It's an honor to follow that comment, Andrea. I think decolonization is kind of a challenging concept because if you truly think about it, it means a full systemic change to colonial structures, mindsets, and institutions. I tend to say toward decolonization and work on steps to getting there. My work is on environment, environmental policy, land and water access, land and water contamination, working in collaboration with tribes, Native communities, and Native nonprofits. And so moving towards decolonization means centering opportunities for Indigenous leadership and land and water stewardship, using Indigenous techniques, bringing back the health of landscapes that have been disrupted intensively by colonial policies that involve removal of species, building of dams, focusing on species of financial value rather than their ecosystem placement and their value to communities and their value as central to culture and identity. So towards decolonizing, means land back, means dam removal, means access to traditional foods and medicines that are not impacted by pollution from a variety of sources. Means moving away from ideas that there are sacrifice zones, areas where pollution can take place, areas that are just seen as lost. Moving away from that towards land stewardship and healing and foregrounding Indigenous leadership and land and water management.
Thank you so much, Beth Rose. This idea of moving toward decolonization and constantly trying to improve is such a fabulous message for encouraging us to keep going. And next, if we could hear from Virginia.
I appreciate both Dr. Garcia and Dr. Middleton Manning's perspectives on this decolonization. So my work is really centered around health policy and ensuring that American Indians and Alaska Natives in the United States have access to healthcare no matter where they live, both in a rural or tribal setting and in an urban setting. In California, 90% of our American Indian population lives in an urban setting. And, first I want to just acknowledge that the healthcare system that we work in is a colonial model. It is based in Western and mainstream methods. And so when I'm doing health advocacy and health policy is to increase funding within a colonial model. There are times where I really appreciate the towards decolonization and the centering of Indigenous knowledge as being ways to think about this, because yes, a decolonized model would be to take it all apart and rebuild it. And I think what we're trying to do is make the system better, to broaden it. And for me, that looks like ensuring that traditional services are billable services, that we can bill for practices that we know in Indian country to make us better, to make us well. And so I think it also means moving towards health sovereignty. And what does health sovereignty look like for Indigenous peoples? I think it looks different than it does in a Western or a mainstream model.
Thank you so much, Virginia. The idea of the fact that we need to acknowledge we are currently working within a Western system and actually make the changes to move away from that actively is so important. And then finally, if we can hear the perspective from Dr. Mark LeBeau.
Thank you. Just want to do a quick sound check. Are you able to hear me?
Yes.
A little bit of technical difficulties, apologize.
No problem, thank you.
So to the question, really appreciate this session and the forum leaders raising this question. And an approach that we take at the California Rural Indian Health Board is to listen to Indigenous peoples in this region in California, including when they share about their needs and solutions related to health and wellness. And in particular, it's important to ensure that I understand and that the California Rural Indian Health Board understands their perspectives, and then work with and for them to achieve those goals. It is important to then work with them and for them in a way of being a good listener. And sometimes that takes quite a bit of time and practice. Sometimes being a good listener isn't easy. It might involve building trust with tribal elders, leaders, or family members before even beginning to dialogue about the topic of health needs and their solutions. Where I work, it often involves conducting culturally appropriate research, working with Indigenous people to gather legislative priorities to address the issues, then writing proposals to fund those services and initiatives. It can also entail partnership with them in their traditional Indigenous ceremonies and cultural sessions. And I underscore that last point because that's just as important as advocating on Capitol Hill or within the state capitol for needed services. The importance of engaging community members in topics, cultural activities, sacred places that are important to them must be important to us as a tribal organization as we work collaboratively with them to conduct the good work and fight the good fights. Thank you.
Thank you so much, Mark. And I think that gives us a really great transition to our next question that really asks about how has the imposition of colonial policies regarding health justice and the environment disproportionately affected the communities that you work in? And some of you have already touched on some of those points, but perhaps we could have Beth Rose and Virginia really elaborate on this point. And we can start with Beth Rose.
Yes, thank you. I can give a quick example that deals with beneficial uses of water. So this is a category that can influence water quality standards on rivers and streams. And for many years, there's been a set of beneficial uses, uses that water can be put to. And these include agriculture, recreation, industry, municipal, etc. It was a long fight led by many Indigenous peoples and organizations to add 2 new categories, which came online in 2017, tribal beneficial uses, tribal cultural beneficial uses, and tribal subsistence beneficial uses, as well as broader subsistence beneficial uses, recognizing that there are other communities in addition to Indigenous nations and members that also access and depend on local waterways for food. So fishing in the Delta, for example. But this wasn't recognized statewide. These are optional and can be applied by different regional water boards on water bodies in their region. So far in California, it's only in the Northwest on the Klamath and tributaries that some of the tribal beneficial uses have been applied. And I know there's a struggle to get those uses applied on other water bodies. And it's important because without those uses recognized, people's health won't be protected. If they're regularly fishing out of a waterway in their homeland, and that waterway doesn't have a beneficial use that recognizes tribal subsistence use or broader subsistence use, then they may be ingesting fish that has many contaminants. That water body may not be designated for intensive fishing and subsistence. So this is important. This is an important intervention in environmental policy that can protect Indigenous health and the health of other community members who depend on local water bodies for food.
Thank you so much, Beth Rose. That is such an important point, bringing up especially water, which is necessary for all humans. And as the state currently defines the human right to water and the needs that they put into that bill, it really doesn't address the specific uses of specific communities that you're talking about. And that is really important to highlight how that should be really promoted on educating our public. And then it'd be great to hear from Virginia on this topic too.
Thank you. And thank you, Beth Rose, for your words on that. I come from the Klamath River, so you know that those topics are near and dear to me, and grew up gillnet fishing on the Klamath River, which is a privilege. And many Indigenous peoples in the West Coast don't have that privilege. For me, when I think about how has colonial policies impacted Indigenous health, I think it's directly correlated to American Indian Alaska Native people suffering from the highest rates of, and insert really anything, the highest rates of suicide, the highest rates of diabetes, the highest rates of heart disease, the most likely to die in a motor vehicle accident. I mean, you can really choose any topic. If we're going to bring it current and talk 2021, American Indian Alaska Natives are also being disproportionately impacted by the COVID-19 pandemic. We are 3.5 times more likely to contract COVID-19. We're 5 times more likely to be hospitalized, 2 times more likely to die. And in our younger categories, we're 10 times more likely to die than our non-Hispanic white counterparts. So that's the bad news. The good news is we have seen Indigenous models work. And when we think about COVID-19, again, as an example, we have seen in many tribal communities an incredible response. So when we have something like a family needs to be on quarantine, we've had tribal communities take an Indigenous approach to this and bring that family food at their doorstep day after day, ensure that they have everything that they need, and an understanding that healing is a community approach, which is not happening here in Western mainstream Sacramento, but it is happening throughout Indigenous communities. We've also seen vaccine policies taken through a tribal sovereignty lens that counter what we see the state of California doing or federal governments. So we have seen tribes get vaccine allocations and say, we're not just going to vaccinate the 65 plus, we're going to vaccinate the whole family that brings their grandparent or parent to the space. And we don't need you to prove that you're a healthcare provider. We're going to acknowledge and respect that clearly you're a healthcare provider. Clearly you are bringing this person in. And so I'm inspired by Indigenous ways of thinking that are so moving and so powerful. I just spoke to a tribal leader yesterday who said that 90% of the elders on their tribal enrollment list are vaccinated and they're care providers. And we're talking whole household approaches. And for those who have chosen not to, how the tribe has decided to support those families and those households to ensure that they're protected are ways that keep me inspired.
Awesome. Thank you so much, Virginia. And that leads us perfectly into the next question as you talk about these changes that are actually coming into play to move toward that decolonized space to provide healthcare equally. And so our next question is, can you describe a current strategy within the community or institutional spaces that you work in that strives to reclaim, revive, or infuse traditional Indigenous wellness practices and pre-colonial ways of living to promote health and healing? And to start us off with this question, perhaps we could start with Andrea.
Sure. So talk about working for an institution, a very big institution at the county level, and trying to maintain this balance. So in my clinical work, I work at the American Indian Counseling Center, which is a directly operated clinic within the LA County Department of Mental Health. So we're privileged to have an abundance, if not majority, of Native staff. And while having Native staff alone is certainly helpful in promoting a healing atmosphere, our clinic is very thoughtful about the way we think about infusing cultural practices into our clinic on par with the very real expectations of productivity, billing, and liability within a county system. So first of all, we started a cultural integration committee. It's not enough to say we're Native, so it's all good, especially in a community as diverse as ours. So we decided to be more intentional. Our cultural integration committee collectively decides how we want to be in relationship with each other, how we train our own staff in cultural humility, and what cultural topics we value and teach. And then lastly, what cultural pieces or practices or ideologies may be implemented in our own clinical encounters and even in patient groups, for instance. Next, I think we're creative in how we navigate what might not be seen as a billable service, but still something we want our patients to benefit from. So we have relationships and partnerships with other Native nonprofits, for instance, who may have more flexibility in operations. And we have relationships with community in general, who are elders, traditional healers, organizers, knowledge keepers, etc. And it's these connections to community that allow us to be nimble as a county-run organization, but really brings our patients that community connection and sense of self that's so pertinent in their healing. Again, we've all mentioned that we know the answers, we know these things work, so how can we connect our patient population with these practices? Third, some of our staff have research backgrounds and actively engage in work that provides the evidence, saying that these cultural practices work in health and healing. And I say air quotes to evidence because, again, we know these work, yet within the very westernized systems that we operate in, we have to justify using these practices in the clinical setting. So it's also one thing to know and reclaim wellness practices at the tribal and community level, but it's a whole other beast to try and implement in systems that center white supremacy. And unfortunately, the more evidence we have to say that these things work, the more hope we have of one day justifying our time on them. So to that end, I have some flexibility in my job to actually take a step back and think about the ways these sorts of practices might one day be supported by the system. Right now, I'm thinking about CalAIM and opportunities within our departmental racial equity work. So these are things we must also learn and think about when making sure these practices can reach subsequent generations and within the context, again, of larger institutions.
Thank you so much, Andrea. I really, I thought it was really inspiring when you mentioned having all of us having to live this balance of being part of these enormous institutions while trying to do what is essentially right toward moving to practices that are more inclusive, and also your emphasis on being creative and nimble and flexible, and like taking advantage of the flexibility within the professional space that you have to start building toward that. That's something that we should always keep in mind. And perhaps we could hear from Mark on this topic also.
Yes, I'd be glad to give input on the question of identifying a current strategy within the community that I am privileged to work in terms of reclaiming, for example, traditional Indigenous wellness practices in pre-colonial ways to promote health and healing. A couple of strategies come to mind that we've engaged in through the California Rural Indian Health Board for over 30 decades. One of those is the annual Traditional Indian Health Gathering. That's a gathering that brings together tribes from throughout California, in particular traditional healers, traditional cultural practitioners, and we come together on a regular basis, gather together for multiple days and share our best practices to helping our Indigenous peoples to heal within the region. And a part of that healing doesn't just involve gathering together. Take, for example, in a traditional roundhouse around a ceremonial sacred fire where healing work is conducted, but also bringing together cultural practitioners to help us remember, engage in revitalization of how to access our traditional medicines through plants, certain trees, roots that are available, when to gather them, how to gather them, in what kind of way must we approach accessing our relative, that plant, for example. What are the stories that go along with that important Indigenous process? And so that kind of work has been taking place over 30 years. It is intended for Indigenous peoples in the region, and very much has assisted in helping people to heal, not only with their certain health conditions and ailments, but also helping them to heal through loss of a loved one, a community member, a relative. And so that kind of gathering our communities can count on. With the pandemic, we did forego having that gathering last year. But one of the things that I know that all of us are doing who participate in that annual traditional Indigenous gathering is that we continue our traditions, we continue our ceremonies, often at home right now, and we're very much looking forward to the turn of the corner in the pandemic so that we can reconvene together. But during this time where we have been primarily, sheltering in place at home, it really is true that it doesn't matter where you are on Mother Earth. You can engage in accessing your ceremonies in certain ways. You also can engage in accessing your ancestors and your creators. Don't always need to come together to do that. So I think that's been a real important lesson for me as an individual during this time. I do look forward to that traditional Indian health gathering. It does serve to recharge me revitalize me, help me, and in turn, we help each other in that kind of cultural engagement. We bring the best of our best, our sacred knowledge together in that kind of environment. And that's something really important. It is very unique cultural initiatives that are brought forward that can be shared in a group setting with other tribes. So there's a lot of understanding that has to go into convening those kinds of events where multiple tribes and their sacred knowledge and traditional healing practices are brought together. You have to make sure to adhere to those rules for those ceremonies that derive from those particular tribes, and make sure that they're okay to share in a larger group setting kind of way. And so the intricacies of moving through that kind of cultural session, you really need to have knowledgeable elders, traditional wisdom keepers to help guide that kind of gathering. It's nothing to play with. It's not something to take lightly. It's not a fun weekend kind of event. It is something very, very, very significant. But yeah, that kind of gathering has been happening in California for over 30 years. It is kept rather quiet, and I think that's very intentional as we focus on ourselves as communities of Indigenous peoples. We focus on ourselves and healing ourselves in our own ways with methods that we know that work, that have been handed down often since the beginning of time. Many of those ancient songs and ceremonies, are continued to be carried on through the families. And so to have some of that critically important information shared in those kinds of sessions is really a great honor and a great responsibility. But that is one example of a strategy that we utilize with tribal communities through the California Rural Indian Health Board to stimulate and promote health and wellness among our people.
Thank you so much, Mark. And I think with that, and a lot of statements from other panelists have given us kind of ways that the system can move toward these new practices that really integrate community voices and authentically community sourced knowledge. And going back to Andrea's statement that our communities already have the answers, and then acknowledging that we're working in this very westernized space that doesn't thoroughly acknowledge that existing knowledge is really something that we all need to move forward in doing much better. But thank you for all of your participation in this panel. I think I personally learned a ton, and all of your words are extremely inspiring toward breaking down these power hierarchies that we all live in right now and moving toward a more integrated system. And with that, I'd like to pass the mic over to Dr. Ndola Prata, who is the co-director of the UC Global Health Institute's Women's Health, Gender, and Empowerment Center of Expertise from UC Berkeley. Thank you so much.
Thank you, Sam. My name is Ndola Prata, and I will be moderating the global panel. I am the co-director for the Women's Health, Gender, and Empowerment of the UCGHI, and also a professor of maternal and child and adolescent health at University of California, Berkeley School of Public Health. It's my pleasure to introduce you to a great sort of array of diverse experiences and backgrounds for this panel. Dr. Elvin Gang is a professor of medicine at the Washington University School of Medicine in St. Louis. Dr. Eric Gosby is a professor of medicine at University of California, San Francisco. And Miss Hollis Wong Ware is a singer, songwriter, Grammy nominee, facilitator and educator, and also a community advocate. So thank you so much for participating in this panel. So I wanted to start by saying that I feel like to decolonize global health for health equity is to remove all forms of supremacy within all spaces of global health practice, within countries, between countries, and at the global level. So I'm going to start by asking you a question. How well equipped is the current global health ecosystem to address health inequalities? And while you're answering this question, I would like you to provide some specific examples from your work and or your lived experiences so that the audience could learn a little bit more about you. So let me start with Elvin.
Yeah, so good morning or good afternoon. It's a real pleasure to be here and have a chance to maybe put some thoughts forward about your question, which I think is a good and deep question for us to reflect on. You know, one thing that I have been reflecting on as a physician and as somebody who's trained in internal medicine and infectious diseases, that many of the issues that come up in global health are, you know, in fact, as they relate particularly to equity, to power, to history, and to structures that promote and create inequity, are not medical. Right, they're not clinical, and if you look at global health, sort of, so you know, competencies that have been put forward, I think that a lot of it still takes a very clinical or medical view on it, and perhaps an economic view on it. So when students come to me and they say they're interested in global health, you know, what should I do? What should I read? You know, of course, I refer them to the public health literature, but I also say things, you know, like you should read Chinua Achebe and understand what the experience of colonization is like, because even though sometimes in certain parts of those that is the backdrop for the work that is being done today and the work that needs to be done. And I think things like that offer us perspectives that will help frame and set the course for what we want to do. I think that clinical medicine is a means to an ends, but that understanding of history helps us understand what the ends ought to be. So maybe just, you know, a few thoughts from me, but you know, eager to hear from my esteemed co-panelists.
Thank you, Elvin. I will repeat the question again for Hollis. Hollis, how well equipped is the current global health ecosystem to address health inequalities? And we wanted to hear from your work, your lived experiences, and if you can provide some examples.
Sure. Thank you so much, Ndola, for having me. And you know, I'm the only non-doctor here, and I'm thankful to be included in my perspective as an artist. I think for me, I'm not a content expert when it comes to global public health. All I can speak on is my perspective as somebody who is both an American citizen and also the daughter of a colonial subject. My mother grew up in Hong Kong and moved here, and so my interest in what colonialism is and decolonialism really stems from the lineage that I come from, and then also understanding my responsibility and accountability as an American citizen, recognizing that we do continue to live in a colonial and imperialist environment. And what is our responsibility as American citizens to be global citizens? And if we are not content experts or not doctors or policy stewards, how are we as artists, as creatives, as interested and passionate global citizens contributing and plugging in to advocating for those who are marginalized within our society? So I think for me, what this question brings to light is just thinking about how we within our advocacy role and our privileges that we have as a developed nation, as folks that are American citizens, how are we leveraging the platforms and the voice that we have to ensuring that we're centering the voices of those who have not been heard. I really loved all of the content that was said in the last panel in terms of indigeneity and thinking about how can we actually see global indigeneity as something that we are advocating for in our work as artists, as creatives, as concerned citizens, and recognizing that we really do have a culture of global health unwellness. We are living in a place where, because of those colonial structures that continue to evolve and thrive today, we are not living in a post-colonial world. We are living in an evolved colonialism. And I want to respect and think about the fact that the United States is currently occupying colonies such as Puerto Rico and the state of Hawaii and Guam. How are we seeing our responsibility within internally and domestically, and the precedent and the resource that can set for how we engage globally?
Thank you, Hollis. And I certainly, being a physician, but part of the global health movement to decolonize global health, I think that we actually need all of sort of a support and allies from different disciplines. So your participation in this discussion is extremely important. So Eric, can we hear from you about the same issue?
Sure, certainly. It really is an honor to be part of the panel discussion on such a challenging, but I think relevant topic. It is a pervasive impact that colonization has on the society that is occupied, engaged, and it's never a relationship that has a process that allows for a assessment of the colonized views of how they're being colonized. It is usually forced upon them in one way or another. And what I see in the commonality of the response, both looking at domestic program development in the United States and Europe in developed settings, but also looking at a expansion of clinic systems in resource poor settings in the United States, inner cities and rural, and in my work internationally, taking services that are for the diagnosis and treatment of HIV and TB to communities that have lived through the colonized period and have evolved as that post-colonial maturation occurs. And I think the distinction that my colleagues have made is a real important one. It has not been a post-colonization or it has been a strengthening and evolution of that colonized relationship, the relationships that were defined in the colonization, and the colonized people's self-perception that has changed. And this, to me, is the commonality of the response in both developed and developing settings that we see historically. The individual that is the colonizer brings a expectation that impacts the colonized in ways that ultimately alters the self-perception of that individual, that community, that social network that was interrupted. And our understanding of that is getting more and more sophisticated, but I see it directly related to the type of corrective action or strengthening of the indigenous population's ability to regain control of their lives, that self-perception difference. So for me, taking a delivery system that is not 1 or 2 clinics in a capital in a city, but expanding that to 300 or 350 clinical sites that can diagnose, treat, and manage a disease that spans a lifetime in HIV has given me those glimpses. Individual communities that acknowledge the self-perception is part of their ability to strengthen their response and address those feelings within their community as only they can, to pivot into what I think is necessary to regain and diminish the chaos that a colonized setting instills. So I'll stop at that.
Thank you, Eric. And I wanted to tie in a bit about the conversation from the previous panel, the Indigenous panel, and see what do you think are the parallels in terms of the ways forward when we're talking about decolonization in our with the sort of a global health perspective. And let me start with Hollis.
Sure, thank you so much. And yeah, I'm actually, Eric, I really think that your point of self-perception is so important. And I think that that also extends to not only the self-perception of the colonized subjects or the folks that are experiencing the ill effects of colonialism and the ways in which that dehumanizes and inhibits folks from experiencing full lives and being full people. I think there's also a self-awareness and a self-perception that needs to be reckoned with within those who would be considered the colonizer. And in the same way that we've done this reckoning over the popularized reckoning of racial equity and racial injustice over the last year, in which folks that are white are recognizing that despite, you don't have to do anything at all to be complicit in white supremacy. In fact, your inaction is indeed an action. So too do I want to expand that to those of us who do live within the privileges of a colonizer mentality, or the colonizer's privileges. Are the self-awareness works both ways, and both identities are shaped by that power, that unequal power dynamic and that power balance. I think for myself, I started my career actually in the nonprofit sector. And I think what I really saw within the nonprofit sector was this put on sense of altruism that actually evaded accountability. And so that's what I was really interested in seeing how these structures that are supposedly altruistic and even consider themselves to be charitable are actually upholding a lot of the dynamics of colonialism and causing them to be more firmly rooted under the guise of goodness and benevolence, when really actually they are reinforcing these colonial structures that ensure the inequities in which our society and our global systems continue to function. I was really surprised in the ways in which, the colonial vestiges or these evolved colonial power structures show up in nonprofit structures, or in the ways that, let's say, like billionaires, who are directly responsible for the widening wealth inequity, will find ways of laundering their reputation within the nonprofit system in order to seem as though they are benevolent or as though they are altruistic. So I would like to move away from altruism. I'd like to see the move and the shifts towards accountability, and towards this idea of that self-reflection and that identity creation. We are all doing it in real time. And it's not just about enabling and resourcing the folks who are colonial subjects or who are experiencing the ill effects of colonialism to self-determine, but it's also really to redefine and shift what does authority mean and what does our responsibility mean? Do we truly feel like our liberation is bound up with each other, or are we operating from a place of charity and thus kind of extending this whole colonial concept of superiority?
I think you're right.
Thank you, Hollis. Can I just ask the panelists to speak slowly? We have a simultaneous translation, and it's we need to speak a little bit slowly. Thank you so much. Let me come back to Elvin and get his perspective.
Yeah, I think heard a lot of great things from my colleagues here, and just want to echo that. I think as we work, I like the terminology of towards decolonizing health and global health, and thinking about both sort of incremental action and sort of paradigm shift. I think there are opportunities to think about these things in both ways, and in fact, these things are sort of linked to each other. And what I mean in terms of global health is that there are sort of systems and structures which are imperfect, but sort of governance, community, other systems and structures in which we can today sort of negotiate and advance certain perspectives that will help bring us towards equity. Not sort of recognizing that that these things are incremental changes, and that they won't bring about the kinds of solutions that we want to see immediately. And an investment in those things and understanding how those things work, the global system, health systems, the global way that I think sort of health goods are distributed, particularly, looking at, say, like COVAX today, doesn't mean that there aren't, that doesn't mean that we can't wait for and look for a convergence of, the stars to align for greater and more rapid change, right? In fact, the idea that that we push for paradigm change versus incremental improvement is probably a false dichotomy. I think we are looking for both, and so I think being sort of savvy about the systems that exist and how to push them in the right ways through multidisciplinary advocacy, through both science and the arts, through practice and research, I think are all a part of the same movement, and also why I like today's conversation so much, because it brings together so many different threads, and powerfully so.
Thank you, Alvin. So I wanted to tell you that we have asked all of the participants to the UC Global Health Day to write to us one word that comes to their mind when they think about decolonizing global health. And I'm going to ask help to project a word map so you can see these are the important words, and the size of the word in this map reflects how frequent the word was mentioned. So we see equity as a big, but collaboration, diversity, justice, indigenous, anti-racism. So let me start with Eric. Eric, can you use one of these words and try to elaborate a little bit? And what does it mean in the context of the work that you do when you think about decolonizing global health? You are on mute, Eric.
Thanks. Thank you, Nigdolas, for that. I would choose the word disparity, and I see it's in a lowercase, but in my work, it is the ability to define a disparity in a health outcome, quantitate it, and concretize that issue in the policy discussions that you are able to engage with domestic, local leadership in the country, both civil society as well as government, and donor foundation engagement. That ability to talk to a different outcome in the population that you're trying to develop services for becomes the continuous objectifier that keeps the interest on program and prevents a receding of that investment. It still can be receded, but and eventually will, but it holds the attention of those so concerned that they put up resources to begin to address it. It also buys you time to broaden that dialogue with that funding source, be it a multilateral, a bilateral, or a foundation, to begin to have lines of accountability in their effort and investment that are missing from most of the global health work. And that's a longer discussion, but I believe it's the core at what will allow Indigenous orchestration and organizing to articulate the focus of the foul in the colonizing effort that creates the disparity that now the Indigenous population wants to talk to those who have been responding, I would say, from afar to address it, and brings that accountability and responsibility for the response back to those who are responsible for it, the government of that country, the civil society of that country, and I would include the private sector in that, and those multilateral foundation and bilateral efforts that want to invest in what is their responsibility to complete and finish. And it's that lack of accountability that puts us in these startup moments for 3 to 5 years that keep waxing and waning, and no linear movement on the larger disparity is addressed.
Thank you, Eric. I think that you also, in your description, I could also hear through collaboration, fairness, empowering other communities. Thank you so much. Hollis, do you want us to guide a little bit of a discussion on inclusion, or is there any other word that you would prefer?
Sure, yeah. So I think obviously the biggest word that we see here is equity. And then the word inclusion jumped out at me as well, because I think of the ways in which we've discussed kind of this, the ways in which these terms like diversity, equity, and inclusion have kind of raised to the surface as points of guidance. And I think with inclusion, I think it's a very interesting term and concept when we talk about decolonization. And I, again, just really appreciate Radmilla and the panelists that were on the previous panel in talking about how representation itself is not decolonial. And I would say too that inclusion in its own regard is not actually decolonial, but can actually serve to reinforce colonial structures and colonial concepts of power and power inequity. I think that oftentimes the ways in which we are trying to subvert traditional power dynamics and recognizing the inequity that exists can kind of serve to be representational points of equity instead of actually deconstructing and rebuilding systems and respecting those Indigenous perspectives, the Indigenous knowledge, and the need for Indigenous self-determination, which quite frankly just doesn't exist. And so I think I see the concept of inclusion as a double-edged sword. One, I mean, I feel like I'm a beneficiary of inclusion being part of this conversation today, and I'm thankful that my perspective as an artist and a community advocate and somebody who really believes in grassroots insight and really believes that those who are the most impacted are indeed closest to the solutions that will be sustainable and be equitable. It's very important, and it's an important principle to hold. But on the other hand, thinking about what are we asking people when we include folks, what are we asking them to be included into? And how can those things actually perpetuate or even harm folks deeper by asking them to participate in these evolved colonial power structures where really they just become representational. And as we know, colonialism, a huge facet of how colonialism was able to spread was through the inclusion of colonized subjects to perpetuate and to sustain colonial power structures by very selectively including colonial subjects, giving them a type of power, thus ensuring that these colonial systems are embedded not as binary and are actually, they become more institutionalized and more insidious and harder to extract. So I just want us to think about in this conversation in public health, to me, this is one of the most dire, and most urgent topics, especially as we see this vaccine rollout and the disparities therein. how countries like the United States, who did an awful job of instituting public health policies, are now being rewarded with the access to the vaccine. And that's just from my perspective as a layman. So just thinking about as we move towards evolving our systems, understanding that inclusion alone is not sufficient to truly decolonize what we have.
Thank you, Hollis. Very, very true. Elvin, do you want to tell us a little bit about justice?
Thanks. I'll be brief here. I think as Hollis mentioned and Eric, sort of equity is at the center of this word cloud here. And I think for me, the notion of justice being sort of adjacent to it is provoking and thought provoking. And, I think equity is where we want, I think, to head, but justice and injustice brings, challenges to ask, not necessarily, not just where we're headed, but how we got here, and therefore what we might want to go about changing. So, for example, should our investments in health be proportional to the contexts that create vulnerability for different populations? And if so, that might mean that certain groups should be prioritized for investments for health infrastructure and for funding, and then that takes us closer to a conversation about reparations, which is a step away, which is perhaps a means towards equity, but justice and injustice sort of bring that, I think, into a little bit clearer focus. But nevertheless, I think these are all important sort of concepts and topics that I'm just grateful that there's a conversation about today.
Thank you, Elvin. We are out of time, and we just started to scratch the surface of this very interesting but very complex topic. It seems like that the current global health ecosystem is ill-equipped to address health inequities. We still have a lot to do. Histories of slavery, discrimination, racism are still present in the design of global and public health programs that can result in racial and ethnic inequities in BIPOC communities, but also globally. I do hope that these discussions we started today in this panel can continue. Decolonizing Global Health advances an agenda of revisiting our global health policies, our history, and then sort of applying a lens of a paradigm shift, a leadership shift, but also a knowledge shift. We are still facing a pandemic, and I think that we have this great opportunity to transform global health, rethinking institutional partnerships and approaches. And most importantly, I would like to leave here a message that we can all contribute. We all have a role to play. So thank you so much, Elvin, Eric, and Hollis. And thank you for the organizer for allowing us to discuss this topic. And I will pass now to Sun to moderate the next session. Thank you so much.
Thank you so much, Ndola, and thank you so much to all of our moderators and our panelists. Now, I'm thrilled to announce the first place winners for our UC Global Health Day Creative Expressions Contest for photography, video, and poetry. We received so many incredible submissions. Okay, so for the photography contest, our first place winner is Deborah Chen from UC Berkeley. Her major is molecular environmental biology with a minor in molecular toxicology. The title of her photo, as you can see here, is Almost Homeless. Be sure to check out the website for her powerful personal statement. Congratulations, Deborah. Wonderful job, and thank you so much for sharing your story. And now for the video contest, our first place winner is a team from UC San Diego School of Medicine, Sydney Dong, Sahit Menon, and Tivin Luong. Sydney and Sahit are first-year medical students at UC San Diego, and Tivin is an incoming medical student. The title of their video is Heard, Healed, and Delivered, UC San Diego Student-Run Free Clinic Project Response to the COVID-19 Pandemic. Due to issues with bandwidth, we won't be watching their 2-minute video here together, but we encourage all of you to go to our website and check out this incredible project serving 500 underinsured and uninsured patients. Their efforts are so impressive. Congratulations again to Sydney, Sahet, and Teven. And finally, for our poetry contest, our first place winner is Jeremy Lowe from UC Berkeley. Jeremy is a UCGHI student ambassador, a member of the UCGHI Black Lives Matter Task Force, and he'll be a UCSF PhD student in the fall. Please join me in welcoming Jeremy to the Zoom stage, and he will share his poem with all of you.
Thank you, Son. Hi, everyone. So the name of this poem is called Global Health Violence. Hands up, don't shoot. Let me grab the straps of my boot. It was not my intentions to smoke, but with no access, I was bound to choke. Choke on the air, the pollution you gave, and the nicotine you made me crave. Though not my intentions, I know these were yours, to drown out our voices and the cities you tore, the cities and populations you colonized, while they were living their lives, making sure that babies survive the weather and the ever-changing climate. Remember the one you forced to be climaxed? Now that climate has climaxed to a state of no return. My cities, my populations are at risk to burn. Underneath the destruction you've caused, under the health agenda you've prolonged, the health of millions and billions rely on you, but you don't care as long as your cash flow continues to profit off the lives of the unheard. BIPOC from Asia all the way to Pittsburgh. My people, once free to determine their needs, now rely on you to maintain the peace. As climates rise and wars rage, you still find some way to get paid. Now is the time. The time is now. Your days are numbered. You must relinquish the crown. Our health is wealth, and you know this to be true. Your plans of wickedness about to tell you a new life for my people, my populations to breathe, while you rot in your mental prison underneath the poplar tree. Those bodies you wanted are now seeds to grow us new ones where we can all finally breathe. Thank you.
Wow, Jeremy, thank you so much. That was so powerful. Congratulations to you and congratulations to all of our winners. You can check out our first place, second place, and third place winners on our website and on social media. And now I'm going to pass it over to my colleague, Bridget Smith. She'll be introducing our next speaker.
Thank you, Sun, and congratulations to all the contest winners. Hello all, my name is Bridget Smith, and I'm a PhD student in epidemiology at UC Davis. I'm honored to introduce to you our next keynote speaker, Ms. Laura Mkumba. Laura, originally from Tanzania, is the co-founder of the Duke University Decolonizing Global Health Working Group, and she is also a clinical research assistant at FHI 360. Laura currently works on HIV and COVID prevention trials. Please join me in welcoming Ms. Laura Mkumba.
Thank you, Bridget. Hello, everyone, and I thank you for inviting me to share this space with everyone. And I'm honored to be delivering the keynote for the Early Career Professionals section. And as we're talking about decolonizing global health to advance health equity and ultimately advance health justice, I wanted to take a few minutes to reflect on what decolonizing global health means to me, spend some time talking about the challenges that we might face and the harm that we might face as early career professionals advocating for decolonizing global health, and how we take care of ourselves while doing this work. So as Bridget mentioned, I co-founded the Duke Decolonizing Global Health Working Group during my time at Duke while I was getting my master's. And after graduating from with my degree, I was talking with a close friend and a fellow co-founder, and we were reflecting on our time in graduate school and also reflecting on what it was like to, advocate for decolonizing global health while in the academic field, and what that would look like to advocate for decolonizing global health in a corporate and professional setting. And a common theme that came up during our conversations was this theme of trauma. Trauma in the sense that, we were both women of color who were navigating a very white and male-dominated space in academia, but also this trauma and the harm that came from us for being bold and advocating for decolonizing. And I realized that I also have started to think of this trauma as an invisible line on my diploma, or this invisible line on my transcript. And now I'm starting to realize that I might think of it also as this invisible line on my CV as a professional. And I don't say this to discourage anyone or to be a downer. I say this because it is the truth, and it is my truth. And it is the truth that I carry with me in every space that I enter and every space that I leave. And it is also the truth that is probably very true for everyone else who's listening. And I say that because as early career professionals, we're young and we're the future of global health, and we are bold and courageous, but we are also vulnerable. Vulnerable in the sense that we often don't have the protection of seniority to protect us as we're advocating for this radical change. Decolonizing is calling for a radical and revolutionary effort, because colonization was and is a very violent effort that required the oppression and subjugation of Indigenous people and the erasure of their language and their culture and their knowledge. And colonization has also is embedded in every system that we work in and affects the way that we live and breathe and move through this world. And so when we call for decolonizing, we're calling for this radical change, this revolutionary act. Decolonizing is not just calling for uncolonizing or calling for cosmetic changes in order to make these, this violent system more palatable and to move ourselves to innocence and make ourselves feel better. Decolonizing is not just about a series of checklists to say that we're doing our work with just diversity and with just inclusion, as other panelists have mentioned. Like I said, decolonizing requires very radical change and requires dismantling. And when we talk about with global health, when I think again of decolonizing, I'm thinking of this dismantling, and I imagine taking a wrecking ball or taking a bulldozer to what we know, as global health today. In that recognizing that because global health is rooted in colonialism, therefore rooted in this violent systems such as white supremacy, capitalism, sexism, and racism, global health in itself and global health as we know it today is actually very ill-equipped to address health inequities. And therefore, decolonizing is necessary, and decolonizing global health is a must. But as I said before, this is a very radical and revolutionary change. It forces us to stand up and to push against systems that have been embedded for centuries. Push against systems, like I said, that are embedded within everything that we do, live, and breathe. And so when we are early career professionals entering this field, whether we have just graduated from undergrad or graduate school, or we're starting out in our professional fields, we are recognizing that we don't have that protection. And I can speak from my experiences myself. One thing that I noted is, as a Black African immigrant woman, I often don't have that protection of whiteness and the protection of being a man, or the protection of citizenship to this country as I'm having this conversation in the US. And so what does that mean for me? It means that sometimes when I'm calling for this very necessary and revolutionary radical change, that I'm at risk of harm. And anyone else who is either in my position, whether professionally, but also social and politically, whether you're a fellow Black person or an Indigenous person or a person of color, a woman, a queer person, and any other intersection of marginalization, when we are calling for this radical change and we're pushing against these systems, we're sometimes at risk of this harm from the system itself that tells us that our opinions don't matter and our words don't matter and our existence doesn't matter, but also harm from people who are invested in these systems, invested in keeping global health functioning the way it was meant to, in that we're not always addressing health inequities. People who are invested in profiting from the oppression of others, and also people who unintentionally do not realize that the harm that they perpetuate. And so when we are calling and pushing for that, we're open to that harm. And sometimes we're stuck in this place where we are burnt out and exhausted, where we are questioning whether it is worth it to constantly push these systems, or, in the case of me, as I work full time, sometimes I ask myself, is it worth it, or should I just continue to work my job and, get my paycheck and focus on my career? And for me, the answer always comes to that liberation, that justice, and that fight is very necessary, and it's a must. And that I can't live comfortably and I can't move through this field in this world comfortably, knowing that even despite my best intentions, I am causing harm because I'm operating within a system that is flawed. That sometimes we're using methodologies that are flawed, but methodologies that are violent, that rely on the oppression of others. And again, I don't say this to be a downer, and I don't say this to discourage anyone, but I say this because I want us to recognize that this is the reality that we might face as we're advocating for this movement. And this doesn't even solely apply to those of us who are young or early career professionals. This can be the case of anyone who's really always advocating for radical change against these systems. When you're calling against white supremacy, when you're pushing against racism and misogyny and capitalism, when you're calling for the dismantling of the systems, there is always going to be pushback because the system doesn't want to change. There is always going to be pushback because those who are benefiting from those systems don't want the status quo to change. And a question that I always ask myself as we're doing this movement, and as I'm doing this work, is how do I take care of myself? How do I ensure that I'm cultivating joy and glory as I'm doing this work? Because like I said before, we can be at risk of that burnout, and that white supremacy especially, and capitalism especially, are invested in us being burnt out and tired and exhausted and giving up. And how do I make sure that I have that energy to keep going? How do I make sure that I have that energy to, again, cultivate joy and glory for myself, especially when I'm very much aware and I'm reading the news every day, where someone who looks like me is harmed in their own home or murdered in their own home, when people don't have access to vaccines or equitable access to healthcare, when I am at risk just by existing and just by the social political context that I occupy in this world, that I am at risk of dying and that my life doesn't matter. And as I'm working to change that and create a life and create a world and society where my life does matter, I also have to think of how do I survive while fighting that injustice? How do I take care of myself? And these are questions that I don't necessarily have the answer to, but these are questions that I'm asking and I'm challenging other people in my positions to think about. How do you take care of yourself? How do you ensure there's glory after this? How do we ensure that we are building spaces where you are heard and that everyone is heard? How do we wrestle with this pull to work in this field that we're very passionate in, while recognizing that there's a very important need for change? How do we create joy for ourselves? And the way that I like to approach this, and there's really two ways that I'm thinking of as right now in my practice, is number one, rest. Rest in itself is resistance. Rest is resistance when we're working in a white supremacist and capitalist world that tells us that we have to continuously keep working. And like I said, white supremacy is very invested in our burnout. So resting and taking a moment to take a step back and taking care of ourselves when we are exhausted and we are burnt out and we feel like our voices aren't heard. And the other thing is creating communities with people who are also invested in dismantling these systems. Creating communities with people who I can be accountable to and who can be accountable to me. Creating communities of people where we're all invested in investigating what power we have and how we are disempowered, and recognizing when one person needs to step in and so that you can step out and take a step back and take care of yourself. But also creating a world where we are caring for each other and how we take care of each other. Because part of decolonizing is building better relationships with each other, better relations with the earth, better relations with non-human beings on this earth, creating a just world, dismantling colonialism, like I said. And in order to do that, we have to start with that care with ourselves and care with each other, especially those in our community. And so I leave this encouragement, as we all have heard from all wonderful speakers today who have talked about what the steps that we take to decolonize, how we can decolonize in our work, and what decolonizing really means as we're calling for this radical change, this radical dismantling. And I'm also speaking to people who are also in my position who might also be feeling that burnt out, who might also be feeling exhausted, especially in this past year where we have been bombarded with onslaughts of news that can discourage us, that make us feel like change will never really come, that make us feel that there is no point to fighting because these systems are so strong and so embedded into everything that we do. The word that I leave with you is that rest and take care of yourself, because you are important in this movement. The movement needs you, and you are needed in this world. That even though white supremacy in this world might tell you that you don't matter, I'm here to tell you that you do matter, and that your opinion matters, and the work that you do matters, and that this work matters. Because if we are going to inherit global health, as we are the future of global health, we have to build and call for a better global health field, a better global health world. In order to do that, we have to dismantle the one that we have. But as we are creating this new one, let's create a new one where we have joy and liberation and glory, but we're also creating better relationships with ourselves and with each other. So as I close, I just, again, want to encourage everyone who's listening that as we're getting into these movements and these conversations, to always remember to take care of yourself, because you're important and you're worthy and you do deserve it. Thank you.
Wow, thank you so much, Laura, for your amazing keynote. I would like to now introduce to you all our panelists for the Early Career Professionals panel. Again, my name is Bridget Smith, and I'm a PhD student in epidemiology at UC Davis, and I will be the moderator for the Early Career Professionals panel. First, I'd like to introduce to you our panelist, Dr. Johnson Laimo, who's currently a PhD student at UC San Francisco, Nikki Valera Jones, who's a recent Master's of Public Health graduate from UC Los Angeles, and Dr. Siana Inca, who is a UCGHI Global Health Fellowship alum from the University of Dar es Salaam and Mbili University of Health and Allied Sciences. Welcome to the Early Career Professionals panel. We are very excited to have you all here with us today, as it is an honor to hear your thoughts on this topic. And as Laura reminds us, as students and early career professionals, we've played an instrumental role in moving towards decolonizing global health. And so to start us off, we would really love to hear the different perspectives of what decolonizing global health means to you. We've learned today that there are several perspectives. And so perhaps we can start with Nikki on really just elaborating a little bit more on what decolonizing global health means to you.
Thank you, Bridget. I want to start off by saying I'm so honored to be on this panel with such distinguished scholars and folks in the Indigenous and Global panel. So thank you. And to talk about what decolonizing global health means to me, I think the first step would be to actually name the issue, name the problem. I think I echo a lot of folks here in truly talking about decolonizing global health, we really would have to dismantle the entire system. And thinking specifically about health systems, you know, in my research, I focus on maternal and child health care, and really looking at the foundation of our health system here in the US and its racist foundation, looking specifically at how, at the expense of Black women, we were able to develop medical advancements in terms of, you know, learning how to perform a successful cesarean that was done through experimenting on enslaved Black women without their consent, without any anesthesia. And folks may say, oh, this is in the past, this happened, you know, 100 150 years ago, 200 years ago, but we still see these vestiges to this day with the assumption that Black women have some type of higher pain tolerance. And we see this with lapses of critical diagnoses, dismissal of concerns and obstetric care. And I think that would be the first step, is to acknowledge the ways in which colonialism and racism and slavery continue to show up in clinical care to this day. And in terms of trying to mitigate that impact, or trying to, as some folks said, move towards decolonizing global health, I think a step in that direction would be to, as other folks have mentioned, reclaim our traditions and practices. There's been an abundance of research that has supported that doulas and midwives, which is a strong tradition in the Black community, is a very successful intervention in reducing maternal health morbidity and mortality. And having this type of support incorporated into clinical care is critical. And I think that wherever you are in the world, I think this really shifts depending on your culture. If you're Indigenous, if you're African American, knowing what your traditional and local practices are, and having more funding, more representation, and really just understanding how these practices can really help challenge and disrupt these oppressive systems that we have to live within and under. And so that's really what I think of when I think about decolonizing global health. And just one small sliver of it, but I think that's a start in moving this huge ship of racist and colonist medical care towards a more equitable and inclusive environment for Black and Indigenous people.
Thank you, Nikki. And thank you so much for bringing up the example of maternal health and how we can really, how colonization has really made its way into our healthcare system that we see today. So maybe we can hear from Johnson on this question, and I can repeat, really, what does decolonizing global health mean to you?
Thank you a lot. And as the previous panelist, it's a privilege to be here to participate in this discussion. I'm calling in from Dar es Salaam now, so that's good to participate. One aspect, the way I see it on what decolonization means, is it's really reflective on the power imbalances. I know a lot of the previous speaker has talked, but for me, with the experience that I had, is really the power imbalances that exist in global health. And this is very broad, starting from inequity, starting from funding opportunity, decision-making authority. We find that the global north has all of these opportunities to make the decision for the global south. I can mention a specific example from my work. For example, there's a recent paper that was really released recently that showed it was a malaria funding, and most of the institutions that got that funding to do the malaria work were from high-income countries. And actually, we find that most of the malaria work is in low-income countries. And this is not new. By working in TB for many years, we have a lot of funding that is coming challenge TB. It's actually most of the institutions that implement it is for high-income countries. And one quick way I can take from that is that you find that once you have like bilateral association or collaboration between two countries, that's where the systemic power imbalance really come into play. I think countries put their interests, protect that coloniality really takes into play. We have this other example where we have multilateral organization like the Global Fund that really improves in a way that the countries have a little bit of scope in deciding what is to be done in the funding and planning and all that. So it sort of improves, and it really push towards the movement toward decolonization. So those are the kind of approaches. If we look at this more multilateral approach, it could help in a way to dismantle this strong, very country by country coloniality process. So those are the experience that I wanted to share.
Yeah, thank you so much, Johnson. And we can hear from Sienna.
Yes, greetings from Tanzania, Dar es Salaam again. It's really good to be here today with all of you. Thank you so much, the organizers, for the opportunity to participate in this important workshop event, because I really think this is a timely topic. And although I can say that we can talk about it very easily, but I think it is something that needs a lot of thought, because as most of people have said, it is something that is embedded it's a multi-layer challenge. And when I look at decolonization, as Johnson just said, probably for today, because as I said, I think it's a multi-layer thing. It's a systemic issue. It is something that would need both short-term and long-term strategies on how to transition from the state that we are in at the moment to where we think we would want to be, and be very clear on how we can achieve that and who will be on the side to support that. But for today, probably I would just talk about two things. And the first one is, as Johnson said, is the power dynamics. And for this, I would say that, I mean, personally, if I would be very honest, this is a question that I always have. Who sets the standards? Who says that this is the right way and this is not? And whoever says that, how much participation or how much contribution has been taken into consideration from all races, from all kind of people? Because you would find that I always say that most of the time, the developing countries, we are like chasing the wind. I work, my research is mainly in genomics, and I'm really passionate to see that genomics really touch people's lives, that we will be able to impact people's lives. We will be able to develop interventions that will be very practical to our settings and will have, impact in their lives. But you would find that we have a lot of hurdles to achieve that because of the way the system works. You would see that just purchasing reagents or equipment for genomics is quite expensive in Africa. Sometimes it's 3 times the price that you would get the same thing if you are based somewhere else. And why is that? And who sets those standards? And who really, when we talk about equity, when we talk about these powers, who really is keen to follow up that, okay, this is something that is, potential, and, we need everyone to be on the same level, like, fair play. And then at the same time, this researcher who is based, for example, myself, and with all these hurdles, you are supposed to be, when the decisions are made or when there's a competition, it's the same ground. How are you supposed to compete? How are you supposed to, to compete with someone else whose situations, whose, resources, access to resources is quite different from your experience. So I think I've been very lucky to be funded by NIH, and so as you said, I was also a fellow, a Glocal fellowship from the Glocal fellowship program, and I've been really lucky to visit and to be placed in very well developed laboratories and institutions, and I've seen how things are done. I've seen how resources are accessible. I have seen how things are just very different from where we are. and how, and whoever sits on those decision table, I don't know if they know that much. And if they do, I don't know how much consideration do they give. I would give another example. There was a paper that we were supposed to publish, and it went from one journal to another, from one journal to another, and eventually it was published, and later on it received a lot of interest, but it was rejected I don't know how many times. And the questions were, well, we would say they were fair, but fair to who, and who sets the standards? Who says that, this is what it should be? And when you say that, do you really consider the different environments that we have? So the power dynamics, who gets funded, who says that this person is eligible or not. And then there's an issue of equity, as we say. So again, whose agenda, who sets the agenda? So if you come to Tanzania today, if you talk to our president, if you talk to our ministers, they will tell you what they think is important.
Yeah. Yeah, thank you so much, Sienna.
But is important to other people? Is that important to the funder? So I think there are a lot of issues there. It's a systemic issue. It touches a lot of partners, institutions, governments, the funders, the people who are getting funded. And I think in as much as this is a great movement, but it needs a lot of thought. And as Laura said, it's a battle that would really need a lot of effort to win. Thanks.
Definitely. Thank you so much for that. And thank you for sharing your examples. Really what I'm hearing from you all is that we do have an unbalanced power dynamic. And that is something that will definitely move towards that decolonizing global health. And what we've heard today is that there are many perspectives and there's many ways, and there's not one answer on how do we decolonize global health. However, so that is a great transition for us to move on as current students or recent graduates. We're really interested to hear about how your recent teachings or recent work experiences have either prepared you, or what are the challenges that have come with moving towards decolonizing global health. And maybe we can share one example, and we can start with Johnson.
Thanks. I think one example that I can share is as part of our training, we have what is research rotation, whereby students, as part of their training, they are stationed with a place of interest to them, and most of them, they can work into this organization that really sort of do the supremacist tendencies. So you get exposed to this organization and the organization cultures as you are learning, and it prepares you to understand that culture as you are trying to tackle decolonization after graduation. I think that is very helpful. We have colleagues that have worked at federal, national, and local level. I'm currently attached to a local institute of research in Tanzania, and I'm also understanding the challenges that they're experiencing as a local research institution to apply to funding in high-income countries. It's actually very challenging. You have, at least to be successful, you have to team up or collaborate with a high-income university, and you collaborate as an under. You cannot succeed to push it as the sole beneficiary. So that's that we learn with that, and that, I think, from the training really exposes us to this environment that is in actual, after we graduate, we'll get a chance to. And I think the other component, really, just to touch on it, is that the training we have is really multidisciplinary. We have a lot of students from low income, high income. For example, myself, I'm coming from low income country, and being part of that training, it enriches a lot. You get the other perspective from the low income countries, and there's the opportunity to develop the next global leaders, because as Laura was saying, the paradigm shift at the later stage, we really need to have the people that are coming from these marginalized opportunities, not even more women that are coming through the education system is very crucial so that they can be able to make change. And just to touch on that is that when we say inclusion, it really is not about tokenism. You just don't include someone because he's Black or is a woman or is a marginalized, but you have this population adequately trained so that when they participate at a later stage at that level, they can contribute positively, and they're equally well equipped to contribute at that level. So that's what I can give my 2 cents on that.
Absolutely, absolutely. Thank you so much for sharing, Johnson. And I'd like to ask if we can hear from Sienna on just briefly on what are some challenges that come with decolonizing global health that you've seen in your recent teachings or work experience.
Thank you. So again, as I said, because decolonization for me, I think it's something that touches a lot of factors. And one of them is the differences in the way we operate, the differences in the way that the perspectives of how we look at things. So for example, I was talking the other day that, you see, for example, for me to be promoted from one career stage to another at the university, I need certain papers, and those papers need to be of certain criteria that I wouldn't say much about. But these criteria are quite different from what is expected internationally. So it's quite contrary. So it's, it's something that you have to find ways of balancing. I mean, to take into account what is required from you as an early career researcher internationally versus what is required from you as an early career in your country, and I'm not saying which one is better, which one is not, but it's just what it is. So, so for us, you need to find your ways of balancing. And the other thing is, again, the systemic issues that may or may not allow you to do what you think would be, the best at this stage. So again, when we talk about decolonization, we would have to look into details of how these institutions are operating and what kind of environment is there, and taking into consideration these factors and making sure that we look at them in a positive way, because there's a reason for everything. So we are not saying that the environment is not good. It just depends on how and why that environment was set. And it just happened to be not what is, is necessary in the other institutions or in the other part of the world. So I think that is the main challenge that I find. And again, as I said, I would have loved to have so much access to resources and do the research that I want. And sometimes it's not even about the funding. Sometimes you may have the funding in place, but other issues that would maybe hinder you to have the access that you would want to forward your research in time and see the results that you want. And again, also, so if you talk about raising leaders in global health, I think we need to start cultivating that culture of hearing from them and listen to what they think is important, where they are placed, and get the support they need. Because I believe there are very good things. As for example, as I said, I do research in genomics, and one of the things that have been said so much is that African populations are understudied when it comes to genomics. But really, who is really supporting that move? And if you ask me, I would have said that, okay, if that is the case, and you want to raise global health leaders, then you get to listen to them more and see how much support they need. Thank you.
Thank you so much. Thank you so much, Sienna. It definitely resonates that we need to listen more to our early career professionals and our students that are interested in global health, so that we're not recreating a troubled system. Let's hear from Nikki. And the question is, what have been some of the greatest challenges or opportunities that come with decolonizing global health in your work?
Yeah, I'm happy to speak on my experience. I'll try and keep it brief. I would say that I really appreciate what our keynote Laura mentioned earlier about the trauma of doing equity work, health equity work, and really looking at ways and challenging traditional frameworks in public health and in global health, and really how isolating that is. At top tier research institutions, it's not commonplace. It's not designed into the curriculum. And so I have vivid memories of sitting in lecture in class and hearing, traditional public health frameworks of intervention, behavior change. And it's, Black folks are poor, they don't eat right, they don't live right. And we need to have behavior change, health education, and really feeling so like this was just so inaccurate. It's really focusing on a symptom of a problem rather than really going to the root cause. And I remember wanting to speak up and actually speaking up, but just really not getting the type of level of engagement. And I mean, really, there's just not a lot of support at these research institutions for faculty who have experience and expertise using an equity lens. And so a lot of the faculty were just not able to engage. And what that creates is a very isolating experience for BIPOC students. And so what I did eventually to help me move through that, that challenging, isolating experience was to find my community at UCLA. There's, amazing faculty who are doing this work, who really carry a huge burden in addition to them doing their research and their instruction. They also hold spaces for students like me and students of color to really have these engaging conversations and accurate conversations about the impacts of structural racism and colonialism on health disparities. It's really damaging to be in class and a lecture and to hear this revisionist type of history and this behavior change when it's like, but we're not addressing why these environments are so toxic, why there are no grocery stores in Black communities, why there are subpar hospitals and clinics in Black communities. We're not talking about how we got here. We're just talking about the problem. And this is also very common in global health as well. With funding, they're going in and just trying to really treat the symptom of the problem as opposed to really addressing and really giving the tools and resources to the community to do the work. And I think that's also a part of how we can start to address the trauma and the isolation of this work, is really to build strength and really build community amongst ourselves. And for me, that was my saving grace in my program, and what really helped me to persevere when I felt like very alone, actually. And, if it wasn't for the Center for the Study of Social Justice, Racism, and Health at UCLA, and the faculty there and the doctoral students there, creating a safe space for me, it would have been, even more challenging to get my degree. And so that's something that I think that a lot of folks can testify to. And I appreciate our keynote emphasizing joy and rest as well as a means to really deal with the trauma and isolation of doing this type of research.
Great. Thank you so much, Nikki, Johnson, and Sienna, for sharing your perspectives. With this as we're having this discussion on this question, we're hearing we're hearing challenges and we're hearing opportunities that some feel like we have access and others feel like we still have a lot of challenges, and there have been trauma, and the access to being able to be that global health professional or researcher that you want to be can be difficult. And so I really thank you all for sharing your experiences and perspectives on that. And I just want to echo what Laura mentioned during her amazing keynote about taking care of yourself. To you all and any other early career professionals and students that are in the audience working towards decolonizing global health, it is really important that we make sure that we don't move towards that burnout. We are the next generation that are going to be working in this space or are currently working in this space. And so I just want to leave us with a note as we wrap up our panel today, is that it's important for us to recognize that though it may be hard to push for these large transformations, the collaboration with local, global, next generation professionals, researchers, and all people from different professions and disciplines and levels, community, is really important. And as we work with all of us around the world, we can really move towards moving that needle and moving it forward. And so on that note, I would like to thank you all for joining us today. It's been an amazing conversation, and we've had an amazing day during this conference. And I'd like to now hand it over to Sun, who will introduce the plenary speaker. Thank you so much.
Thank you so much, Bridget. And what an incredible keynote by Laura, and such a rich conversation with Bridget, Johnson, Nikki, and Sienna. Thank you all so much. And finally, as we near the end of Global Health Day, it's my honor to introduce our closing plenary speaker, Dr. Javon Johnson. He's an assistant professor and director of African American and African diaspora studies at the University of Nevada, Las Vegas. He is a poet, a new father, and a fellow Californian. Please join me in welcoming Javon.
Hello, how's everyone doing? And first and foremost, thank y'all for having me. I am having a bit of some sort of technical issues, but we'll work it out. I am really sort of just excited to be a part of this with you all. And as I sort of get myself situated, there we go. So I was asked to come on and share a couple of poems with you all, and I guess we'll get that going. So I was contacted to sort of start with one poem, and I'll start with that. I'll move to a newer poem that I wrote, and then sort of finish off with something else that I wrote not too long ago. And each of these touch on race and global health in particular ways in which I see fit. When the cancer comes. When the cancer comes, the experts will gather. They'll say things like, I'm afraid there's bad news. This is not a death sentence. People live long lives. We are doing everything we can, but there is not an exact science to this. Of course, you might hear bad news. You might hear this is a death sentence. You will think to yourselves, humans are everything but not this. Cancer is when the abnormal cells grow and spread very quickly. Sometimes these cells group together, causing damage to healthy parts of the body. Often they'll break away, causing more damage to other healthy parts of the body. And this is the best definition of gentrification that I have. I live in Oakland, where they are tearing down old Black bodies quicker than they could build up new high rises. Death by crooked cop or crooked crane is all the same. Gentrification is killing us. When the new Oakland residents call the cops on the drum circle, which is filled with people of color, they are trying to stop the heartbeat. When they call the cops on the Black church, which had been there for 65 years for being too loud on a Sunday, they are trying to strip Oakland of its soul to gentrify gentrify is to take the body and gut it. It is to treat the entire city like a chop house, and those butchers, they have no manners. They do not pray over the slaughter. They simply toss out the bones as if there's no need to season the stock. There is no God in this. My stepfather was a pastor. And before that, he was a football coach. And before that, he was a truck driver who delivered food items. He was a man who took care of those who were not his own. He was a high yellow man who sang like he tried to call the cattle home. He thought his voice was better than what it was. And we let him sing anyway, because we knew soon he would go the same way of the house he raised us in, all memory, no longer ours, and no longer here. When my mother called me to tell me of his lymphoma, that he only has a few months left to live, for some odd reason, I immediately thought of the mixed income high rise being built just up the street for mixed income families. I thought to myself, the city does not care about the poor Black families in that high rise who will not be able to afford the $10 cup of coffee or to shop at the Whole Foods. The cancer does not care that the body may not be whole or that the body has a family. The city does not care about Black families. That the only place we have ever been called home will be made to feel strange and foreign and out of place. That at this rate, we will have to lower our dead into grounds they could not afford to live on. At some point, mixed income housing only prolongs the inevitable. And this is the best definition of chemotherapy that I have. Meanwhile, my stepfather passed and no one seemed to ask the important questions like how did we get here? And why is the body eating itself alive? And where did the God go at all of this? I am a broken prayer in a burned down church house. Without him, I never would have made it, which is to say I am Black and I am scared. And this is what the cancer does. And it pushes the God out of the body. And sometimes the body has neighborhoods for limbs. When I played football for him, and we lost our semifinals game, I made my fist into two small wrecking balls, waiting for any new project to get into. He said, cry it out if you have to, but you gotta pick your head up, you hear me? You got to figure out the way to get him next time, he said. He is everything I can tell you about gentrification. His story is everything I can tell you about what happens when the cancer finally comes. Thank you very much. I'm gonna switch up real quick. I'm gonna try to the sort of technical difficulties I was having was not in relation to this, but really sort of in relation to me trying to pull up the newer works I had. So I have many poems memorized, and then there's some things that I don't. So bear with me here as I do this real quick, boom, and see what happens. Uh-oh, there it is. I think it's properly working. So boom, okay. Poem number 2. I have no title for this. So I am still thinking through this. So it is where it is at the point. I mean, at the moment, right? The news article reads, Matt Colvin, an Amazon merchant with over 17,000 bottles of hand sanitizer, has nowhere to sell his product after Amazon cracked down on price gouging sellers holding stockpiles of sanitizers and masks. So this means your delivery can only be prime if Jeff Bezos is the only one primed to benefit from hoarding the resources, and the pot stays ever ready to call the kettle black whenever it's not doing capitalism properly. I was 10 years old with a face that was new penny shiny from the cocoa butter my mother slathered on me when my aunt packed me and my cousins, 5 in the back and 2 in the front, in an old paint chip Toyota with no AC to protest Sun Jadu's liquor store after she murdered 15-year-old Latasha Harlins by shooting her in the back. We blocked the entrance with our bodies, with curse words, and whatever signs we could quickly slap together. Our message simple: you can no longer do business here, which means My first major civics lesson was not in voting, but in Black death and protest, and that book is worn thin, y'all. Yet somehow, not enough people have done the reading. There it is. Not enough people have done the reading. As a child, I always loved public libraries. I got lost in the dingy aisles, how they all seemed to smell like a stale yesterday. My favorite book was Where the Wild Things Are. I love that book. I love wild Black kids so much. I eat them so. And today, there is a Black child somewhere who imagines herself as strong as a bear. Another who thinks himself a falcon, a group of Black children who see themselves as a pack of wolves. And we are learning America loves to kill its wild things, and the virus must now be asking the viral video, how the fuck you just gonna show up and steal my shine? Talking about you can't breathe like I ain't got the patent on that. You jumped the line, made your rounds before I could really get to going. I mean, who you think you are? Half them folks are pouring into the streets like grandmama's good gravy thick. I mean, of course I wanted to eat them before you did. Before those other folks wanted to consume all the resources, even when Black people are the resources to be consumed. And the viral video must have responded, you're new here. Look at this. Let me show you something. Come look at this. Look at this. Look at me. Look at this. Look at this. Stick around, kid. If you look at this the way I do, I'll show you how to truly take their breath away. Just watch me. Thank you. Thank you. Last poem. And as I said earlier, I truly do benefit, really sort of appreciative for being asked out to be a part of this. I was able to sit in earlier on a lot of the panels, and I have an iPad full of notes, so I'm glad to have been a student of this as well, and not just someone who is offering up whatever art in service of today. So thank you all. In 1946, Jacques Heim, and forgive me, I don't know how to pronounce French names that well. So in 1946, Jacques Heim introduced the modern bathing suit, a minimalist two-piece design he named the atom, after the smallest known unit of ordinary matter. To promote his design, Heim hired a skywriter to advance, quote, the world's smallest bathing suit, end quote. Not to be outdone, however, Louis Riard, with new dancer Micheline Bernardini and his own team of skywriters, introduced and advertised his version that was, quote, smaller than the smallest bathing suit in the world. He called the swimsuit the bikini. Of course, it was after the Bikini Atoll, a coral reef in the Marshall Island that the US just 5 days prior tested its first of 23 nuclear bombs on. If you strip it down and pay really close attention, you'll see that it's all smoke and mirrors true story. I did not know how expensive avocados are until I became an adult. The woman next door to my grandmother's house had a huge avocado tree. She begged the neighbors to take them down so she wouldn't have to clean her own backyard so frequently. My grandmother, who loved collard greens and mustard greens, often asked me to take some of those greens to the neighbors so that we could trade them for fruits and vegetables, what you all now call a co-op. You once called poor. True story. The Gap Band, who, like my grandmother, were from Oklahoma, got their name from the popular streets of Greenwood, Archer, and Pine in the Greenwood district, a Black neighborhood in Tulsa. More than 2 decades prior to the US testing atomic bombs in the Marshall Islands, they dropped burning turpentine balls via air raid on Greenwood, also known as the Tulsa Massacre on Black Wall Street. If you're still paying close attention, you'd see it's still all the same smoke and mirrors. True story. During the Middle Passage, sharks trailed slave ships from one end to the Atlantic to the other in order to feed one of those that were thrown feed on those that were thrown overboard. Ultimately, the Atlantic slave trade changed the entire ecosystem. This blew my mind when I first read about a true story. When I was young, we labeled everything we thought good the bomb. The burritos on Vernon and Hooper were the bomb. The chicken wings close to my high school were the bomb. Jordan's the bomb. Madden football, the bomb. My Lakers always the bomb. Interestingly enough, the way we treat the environment, often using the bomb, is not therefore the bomb. Yet, if you're still paying close attention, you'd see it's still all explosive. A quick lesson on the bomb. In the mid-20th century, the Las Vegas population doubled and tripled in part because people wanted to be near the atomic bomb testing that regularly occurred in this once isolated desert. They wanted to be near the exciting new science, the mushroom clouds, you know, they wanted to be near everything the bomb, which you might guess is not the bomb. They say it takes an atomic bomb less than a microsecond to fully explode, which means we have no time before it all goes boom. Here's what I know. In 1977, the US worked to clean up the estimated 73,000 cubic meters of radioactive waste it left strewn across the Marshall Islands as a result of the nuclear testing. They created a concrete dome nicknamed the nuclear coffin, and the coffin is now cracked and leaking, which means the dead is spilling out, which means the world is becoming a horror film, which means the monster is already here, which means we have no time left. My grandmother always taught me that if you take care of home, then home will take care of you. From nuclear testing to carbon emissions, some of us treat the planet, really capitalism, treat the planet like an unethical science experiment, which means the ice is melting, the sea level is rising, the planet is warming, the world is toxic, which means we have no time left at this point debating about climate change and who's debating about climate change is like trying to have a philosophical discussion about air with a drowning person. But here's what I know. Climate change is here. Capitalism and colonization is at fault. It can be irreversible by 2030. We are all at risk of losing 1 million species. Major cities will soon be underwater. It will create a refugee crisis. The world's richest populations create the most carbon emissions, and yet the world's poorest populations are most at risk. Climate change is not simply a human issue, but it is a race issue. It is a gender issue. It is a class issue, a sex issue. Some island nations produce near zero emissions, but cannot think about climate change. Instead, they must now think about climate adaptation. In the US, some of us cannot think about the climate because we are too busy up thinking about housing, about food, about the police state, about if our children will be in cages because of the border, about if I will be alive to worry about 2030. What does it mean that I am asked to save a world when the world we established does not want to save me? When Dr. King said we are all caught in an inescapable network of mutuality, he meant we cannot save the oceans without saving the land, without saving the trees, without saving the animals, without saving the homeless, without saving the refugees colonization created, the poor, those without healthcare, or those dying at the hands of the police state, without stopping the greed, without loving those who pray to a different God or those who do not pray to a God at all. True story. Scientists have discovered that 10 years after the US bombed the Bikini Atoll, the ecosystem started to recover. And without human intervention, it is now becoming somewhat thrivable again. What Dr. King meant, what the Bikini Atoll is trying to teach us, is that we cannot save the world for ourselves. We must save the world for the world. And when necessary, we must get out of the way and allow the world to save itself. Thank you all for having me. Thank you, thank you, thank you.
Wow. Thank you so much, Javon. You get me every time. I'm emotional, so I'm not going to turn my video on. I feel comfortable sharing I'm emotional with everyone, but not to ugly cry in front of y'all. What an incredible way to close out UC Global Health Day. Thank you so much to all of our speakers and panelists for such a thought-provoking dialogue on a Saturday. Huge thanks to those of you who tuned in today from all over California, the United States, and the world. There are so many people to thank for making this event possible. Please follow the UC Global Health Institute on social media. We're on Facebook, Twitter, Instagram. And remember to visit our website to check out the winners and honorable mentions for our Creative Expressions contest. As we've heard in this event, throughout the event, that this is the start of many conversations to decolonize global health, to advance health equity. We will be continuing these conversations and rallying towards action as we move forward in this work together. Have a wonderful weekend, everyone, and take good care of yourselves and each other. Bye.